Hello and good evening to everybody that's joining us for this webinar. This is our 8th collaborative patient and public involvement event from Derm Academy here at St John's with the National Eczema Society. And this evening is going to be a great programme. We're going to be focusing on what to expect in terms of how your eczema is likely to behave during pregnancy and also what treatments might be okay and fine to use during conception and during a pregnancy itself. We've got two tremendous guest speakers today, and then at the end we'll have an opportunity for you to ask your questions when we're joined in our panel by a third expert who will be able to contribute to the discussion that we have. You'll be able to put in questions that you'd like to ask for that Q&A session, which we ask you to do from the Q&A function on the Zoom call. The chat's disabled, so that's not going to work for you. But any questions that you've got relating to eczema and pregnancy, conception and after pregnancy, please pop it in the Q&A. You'll be able to see and hear the panelists and presenters, but we can't see or hear you. We will do our best to answer as many of your questions as possible within the time that we've got. We will be sending out, after the event, we'll be sending you out an email so you can give us a bit more in-depth feedback about the event. And we will also be recording tonight's webinar so that if you want to access it later, or if people that haven't been able to join live, you'll be able to access that via the National Eczema Society YouTube channel. If you'd like to make a donation to support the National Eczema Society and the really important work that they do, you can do so via their website. So why don't we kick off with our first speaker today? And it's a great pleasure to introduce Dr. Ruchika Kumari. Now, Ruchika is a clinical fellow in dermatology here at St John's Institute of Dermatology at Guy's and St Thomas's Hospital. And in her current role, she's joined Professor Carsten Floor's research team in her final year of specialty training. She did her undergraduate medical training at University College London Medical School, and she's got a BSc in Medical Sciences with International Health, where importantly she studied maternal and child health as a special interest. Her clinical interests are in adult and paediatric medical dermatology, particularly atopic dermatitis and obstetric dermatology. And in her current research, she's starting to look at the lived experience of patients with atopic dermatitis throughout their pregnancy. So great honour to introduce Ruchika to give us our first talk today. Thank you.
Thank you very much, Gemma. I'm just going to share my slides, so bear with me. Is that visible okay for everyone?
Perfect.
Great. So thank you very much for that really kind introduction. I'm Ruchika Kumari, and I'm going to be spending the next 15 minutes talking to you about what to expect when you're expecting the eczema edition. So a little bit about me that we've already discussed. I am a research fellow. I'm actually currently on maternity leave, but when Gemma asked me if I wanted to do this talk, I couldn't resist because it's something I feel so strongly about. And my study is looking at the lived experience of women with atopic dermatitis or eczema, and also the doctors and clinicians that treat them and how they find that journey. And what this involves is some focus groups and some semi-structured interviews, so some qualitative research in this field. And we're very grateful to the National Eczema Society. So I work with Professor Carsten Floor, and we were awarded a grant by the National Eczema Society looking at a spin-off study from my study, which is LEAD NLP, or natural language processing, which is a kind of artificial intelligence or AI mechanism that we're using to study human language and how we interpret it. So in this talk, I'm going to be using the term eczema to refer to atopic dermatitis. When doctors talk about eczema, we sometimes use it to describe different types of rashes, but in this context, it's atopic eczema or dermatitis that I'm talking about. And as ever, we try to be very inclusive and sensitive to the needs of our patients and our colleagues. And in line with the Royal College of Obstetrics and Gynecology guidance, I'll be using the terms woman and women, but we do acknowledge that there are individuals that do not identify as a woman for whom they might need to access dermatology and reproductive services. So I wanted you to just take a few seconds to think about what really happens to someone during pregnancy. You might be thinking about your own pregnancy or someone that you've seen who's gone through this journey or something that you've read or heard. What do you think actually happens to this person? So here's a slide that I've put together with some of the things that I've thought about. So on the left in the purpley colour, we've got the physiological or physical changes that a person undergoes. So they have hormonal changes, progesterone and estrogen levels rise. They have physical changes, they develop a bump. They may develop stretch marks, varicose veins. Their skin can change. So often there's this sort of um, old wives' tale of you having this pregnancy glow, but actually that doesn't exist for everybody. And people can get pigmentary changes such as melasma. Hair often thickens during the pregnancy, but not for everybody. But then soon after you've given birth, it can start to fall out, and this can be quite dramatic. There's also a change in the immune state of the woman, which I'll come on to a bit later. So these are all really interesting physical changes that happen. But then there's the woman as a whole, as a person. So if we look at the colour in the peach, her career, if she's working, she might need to take a career break, which is very likely, to look after the baby, give birth. She might have to do this sooner than she'd planned because the pregnancy requires this. Relationships with partners, colleagues, and friends can change. She'll have to make lifestyle changes. So, for example, if she's very into fitness, she might have to change what she's doing because she's pregnant. There are certain things that you're not advised to eat or drink. And then lastly, there's the sleep. So I'm on maternity leave at the moment, and one of the first things that people always ask me is, how are you sleeping? How's the baby sleeping? And I don't want to jinx myself, but I'm actually sleeping better now than I was towards the end of my pregnancy. Still not great, could be better. But at the end of my pregnancy, I was quite uncomfortable. You can't lie on your back. You have to keep going to the toilet because the baby is tap dancing on your bladder. So for me personally, sleep was not great in the pregnancy, but that's not the case for everybody. And that's one thing that I really want you to take away from this slide. It's hard to predict what the pregnancy is going to be like, and your first pregnancy might be completely different to your second pregnancy or your sister's pregnancy or your mother's pregnancy. So this is something to bear in mind, that pretty much anything can change, and you have to be sort of able to adapt to that a little bit. And when I was putting these slides together, I thought back to my A levels and when I studied about Maslow's hierarchy of needs, which is a psychology theory about what motivates individuals. And if we look at pregnancy as a life event that happens to a woman, so this person may have a chronic disease like eczema, or they may have never ever been to the doctor before. Suddenly they have this event and their needs are changing and maybe not being met. So in the first trimester, if you're vomiting, and it's not just morning sickness, that's a myth. You can be vomiting throughout the day. You're not going to be getting your food and water in. We've already discussed sleep and employment, and how relationships can change. So this one life event can actually affect an individual on so many different levels. So I thought that was an interesting way to sort of think about what to expect when you're expecting. And it's not just specific to eczema, although it does come into play. So what is happening on the inside during pregnancy? It's really important that the mother's immune system adapts so that the body doesn't reject the baby. What do I mean by this? So we have these T cells in our immune system, and we shift away from the Th1 cells, which are involved in the defense of the body against bacteria and virus, etc., towards a Th2 response. And this is so that we don't end up rejecting the baby. Now, eczema, we know, is very complex and it's caused by many different factors, but overall, it is considered a Th2 dominant disease. And we know that hormonal changes take place, including estrogen and progesterone rising. And we know that can also flare eczema. So looking at this sort of the immune system and what's going on the inside, you might be thinking, right, well, eczema is definitely going to flare in the pregnancy. And it is common for eczema to flare, but not all individuals experience these flares. Some people's skin actually improves. So they might have bad eczema, and then whilst they're pregnant, for some reason, their skin gets much better. whereas others might have very mild eczema, which worsens during the pregnancy, and some stay exactly the same. And the learning point here really is everyone is different and each pregnancy is different. So it's tricky for us to predict. One thing we do know, though, is that certain things trigger eczema, and they are a normal part of pregnancy. So the hormonal changes, the physical stresses, possibly the psychological stresses if you're feeling particularly anxious or anything happens in the pregnancy to worry you, and the poor sleep that we've already discussed. One thing that you should be aware of is that the eczema can vary depending on the trimester you're in. And again, it's not the same for everybody. So, for example, if you've got a lot of sickness in the first trimester, you might be under a lot of strain and your eczema might be playing up quite a lot. For others, it tends to happen much later in the pregnancy when they're struggling to move around and get their emollients on their skin. Another thing that can affect you, for example, is if you're heavily pregnant in the summer and heat and hot weather is a trigger for you, then you're more likely to be flaring in that trimester rather than early on. But the one thing you must remember and expect is that there are things out there that you can do to make your eczema more manageable during pregnancy. There are supportive measures, discussions around your emollients and putting them in the fridge so they're cool, sort of keeping your home environment as cool as you can. If you need letters of support from your doctor to give to work so that things can be adapted there, all these things can be done. And Dr. Wolf's going to be talking to you about the treatment, so I'm not going to overlap here, but there are treatments that can safely be taken if required too. And then what about this phenomenon called the fourth trimester? This is sometimes what we refer to as that immediate postpartum phase when you've got the newborn. Sleep is erratic, we know that. Some people have never had nipple eczema and then develop it, and others that have always had a bit of nipple eczema find breastfeeding can be a little bit tricky. But there's no reason not to breastfeed. That was the advice given at times, but if you want to, healthcare professionals can definitely support you to do that if that is something that you want. So please don't feel that you can't or you shouldn't. Hand eczema can flare. So this little lovely baby at the side showing their nappy is a good picture, I thought, for the number of nappies that you'll be changing and messy things that you'll be cleaning up. You'll be washing your hands a lot. And that can actually trigger hand eczema for some people, and in others, it can just make it a bit worse. And the other consideration is when you're looking at how you're managing your skin, if you're undergoing something like phototherapy or you're on an injectable medication where you need monitoring, how are you going to navigate those appointments? Phototherapy can be 2 or 3 times a week. Sometimes the department will let you take the child with you. Otherwise, you might have to look for somebody to just leave the child with or to accompany you so they can wait with the baby. If you're breastfeeding, have a chat with the department you go to so that all these things can be facilitated for you. So planning ahead is really good to try and help you through this phase. And another thing I wanted to talk about was something that I call the great mimickers of eczema and pregnancy. Now, I've got on the right-hand side here the symptoms that we all know that are very common in eczema. So itching, scratches on the skin, swelling, discomfort. You can be oozing or getting some blisters if you've got Pomflex type eczema. Your skin can look red, or if you're of a darker skin type, it might even look a bit purple. All these things. Now, the conditions I've written on the left, I've actually personally received referrals for quote unquote a flare of eczema in pregnancy, and it's turned out to be one of these other conditions. And I don't want to get down into these other conditions because we haven't got enough time, but some of them are really common. Anemia, so low iron, is very common in pregnant women and in the population in general. Scabies is intensely itchy, and I've seen that. Pemphigoid gestationis is when the immune system causes you to blister, and the initial phase of that can mimic eczema, and I have seen that. So just something to consider. If you feel like your skin is flaring a lot, it might not be your eczema. So always go to the doctor and don't just assume it's your eczema and try and manage by yourself. One thing I want to say is there are therapeutic contributions to flares. What do I mean by this? So some women may choose when they become pregnant or if they're planning pregnancy to scale back their medicine. If whatever they are taking, they might not want to take as strong a medication or they might not want to take any at all. that is completely a personal choice, and that's okay. And doctors and midwives and everybody will support you through that if that is your choice. There are cultural considerations. So, for example, rather than emollients, in some cultures, they might choose to use things like yogurt or turmeric-based preparations during pregnancy. Unfortunately, sometimes there is pressure or suggestions from others, and this is something that you have to consider and also discuss openly with your doctor so we can try and support you through this. Because sadly, that is something that people experience during their pregnancy, and it's not unique to eczema. So, what may actually influence the treatment decision of individuals? There is evidence that there are unmet needs of women of childbearing age with chronic diseases around pregnancy, and these range from a lack of patient support to inadequate specialist discussions. And one of my supervisors for my higher degree, Kathy Nelson Piercy, has done a lot of work around this area, and it's very interesting to see what comes through. From a clinician's perspective, there are no large clinical trials we have available for pregnancy and eczema. So when we're having these discussions, sometimes that might make people, doctors and patients feel a little bit uncomfortable about where are we getting this evidence for the treatment from. But it's important to find a balance because there have been times where people have been told, just wait it out, it's 9 months. But we know for a fact, and I've seen it personally myself, that this can have a significant impact on the individual that's pregnant. It isn't just 9 months. You've got to then think about the postpartum period and how they feel about future pregnancies. And 9 months is a long time to wait it out if you're not feeling comfortable or your skin is flaring. So it's really important to find this balance. Now, one thing we do have are anecdotal case reports, and a lot of collaborative work is being done internationally amongst experts. So the last paper here that I've referenced is a position paper based on specialists throughout Europe who have looked at the evidence around treatments for AD or eczema, and they've come out with a position paper with guidance on this. So that's a really reassuring source that you can use alongside your team of midwives and doctors to sort of make a plan for yourself. And we can also look at the findings from other specialties. So we have overlapping treatments with respiratory medicine, rheumatology, and gastroenterology. And we have patients in those specialties that are using certain treatments that we also use. And we can look at what's happening in those fields to help guide our discussions and involve patients in shared decision making. So really my point is you should expect to be involved in the shared decision making of your treatment. Again, I'm not going to go in detail about this because this is a talk in itself, but should I expect my baby to develop eczema? Well, atopic conditions run in families. And if your partner also has asthma, eczema, or hay fever, there is an increased chance that your child may develop eczema. It's unpredictable if your baby will develop it. And the other thing to remember is it's unpredictable how severe their eczema will be. So just because you have severe eczema, that doesn't mean your baby will. They may have a milder form, which they grow out of. And it's really important to remember it's not your fault if they do develop eczema. It's very, very unlikely that it was something that you did or ate that caused them to get this. As I said, eczema is very complicated. There are many genes and considerations at play. So remember not to blame yourself, or if you're hearing things or reading things that it's your fault, please try not to take that on board. So what should you expect? You should expect to be able to access support if and when you need it. If you're planning pregnancy, so it's not always planned, but if you are, try to optimize your skin and inflammatory levels before you become pregnant. And work on those iron levels. Vitamin D is another one that you can work on because this gives you the best chance of having healthy skin, at least at the start of the pregnancy. And I'm not talking about infertility and preconception phases today, but there is some evidence to suggest that if the inflammation is better controlled, fertility is also improved. And it's important to discuss therapeutic options ahead of time so you can research and read around them and make an informed decision. Try and be flexible. Try not to think this is exactly what I'm doing, or I will not have this, or I will have this, because there's no reliable way to predict how your eczema will behave and how you will be feeling. I think it's really important to seek advice early and know that there are treatment options available. And it's, no one's ever going to force you to take anything you don't feel comfortable taking. So please just be reassured that we are here to support and help you. And do consider the postpartum period and the things that you can plan to help you around that. So just to finish off, I wanted to share a little bit about my project, so the lived experience of women with atopic dermatitis and the healthcare professionals that treat them. We're currently in the process of recruiting the healthcare professionals for this study, and very soon we hope to be opening to the public to recruit women of childbearing age. So what this will involve is, like I said, with focus groups where you sit in a group with me and a couple of other individuals to talk about your experiences of living with eczema. You don't have to have been pregnant. Equally, you don't have to be pregnant right now. You may have been through the whole phase. So if you are interested, we will be promoting through the National Eczema Society, but you can also email us on the lead study at kcl.ac.uk. And once we're open for recruitment, we can get in touch with our patient information sheets and a bit more information. So thank you very much for your time, and I'll hand over to Gemma and Rick. Thank you.
Brilliant, Ruchika. What a lovely holistic overview of the area. It's really great to have had your insights for that. So we're going to hand over now to Dr. Rick Wolf, who's a consultant dermatologist here at St John's Institute at Guy's and St Thomas's Hospital, where he's a consultant dermatologist. He qualified from Bristol University and completed his integrated academic training in dermatology at St John's, and he's also completed his MRC-funded PhD in skin immunobiology at King's College London in 2015. His key clinical interests are also medical dermatology, and he works across our very large specialist clinics in the eczema and psoriasis services. As well as his clinical work, he's an investigator on multiple clinical trials in those and related disorders. So a real expert and a treat for us to have speaking today. Thanks, Rick.
Thank you, Gemma. I'll just start by sharing my slides. Can I just check that you can see that?
Not yet. Help
Can
is
you
on
see
the way.
All right, okay, sorry. Oh.
Now we can.
Perfect.
Perfect, thank you.
So thank you, Gemma. So just to very briefly introduce, I'm a consultant dermatologist and I work with adult patients with severe eczema, and I'm also heavily involved in trials of new therapies. So hopefully this nicely follows on from Ruchika's talk, where I'm going to pick up the baton and talk a little bit about the way we approach treating individuals, women of childbearing potential in conception and then in pregnancy. And just to set the scene, sorry, as I think Ruchika nicely demonstrated, but you know, the clinical course of eczema can be highly variable from individual to individual, and in many aspects it's very difficult to predict or anticipate in which way the eczema may go. Broadly speaking, as she mentioned about this immune shift, there is a tendency or trend towards people's eczema getting a little worse, or people developing new eczema in pregnancy when they may not have had this before. And these are just some typical images of people with localized or more generalized eczema in pregnancy. And the way, you know, our decision to treat eczema is very individual. So it's largely dependent on the impact of the condition on the individual. If you talk to patients with eczema, often the dominant symptoms that they'll report are itch, skin pain, and sleep disturbance. But more broadly, significant conditions like eczema and other inflammatory conditions have huge impacts on individuals across many aspects of their lives, whether it's from their individual experience, so the physical symptoms that I just mentioned, through to their personal relationships and their ability to work or study. And as we've touched on, there are specific additional considerations in conception and pregnancy. So you have the mother's well-being, the impact of eczema on the ability to conceive, and the fetus or the baby's well-being. And Ruchika, I think, mentioned that the evidence is not great out there, but there is a general trend with poorly controlled inflammatory skin conditions and other inflammatory conditions, whether it's rheumatological or gastrointestinal, that poorly controlled inflammatory skin disease can potentially negatively impact on pregnancy outcome. And usually that relates in the studies in eczema around small foedate or early delivery. Eczema is not associated with congenital malformations or miscarriage. Obviously, having poorly controlled skin can also impact on your, on intimate relationships, your ability to conceive. But the counterweight to all of this and this intervention is, the instinct and the intent to not harm your baby. So to stay in optimal health, but also not expose your baby to something that may be of harm. Again, Ruchika talked about the general inflammatory nature of eczema. This simple schematic shows that there's this negative kind of cycle going on in the skin when we see established eczema. At the top left, we broadly acknowledge that when you have eczema skin, which is naturally a bit drier than healthy skin, the barrier function of that skin is impaired. So things get into the skin that shouldn't be there. This leads to chronic inflammation. So the immune system is overactive, and this has this bias. It's a technical term, but there's type 2 type response. And then we know that that inflammation makes the barrier worse. So you get into this negative cycle. And when it comes to treatments for eczema, and this is whether you're pregnant or not, if you're in male and female patients, broadly speaking, our treatments target these two aspects. So interventions that maintain barrier function, and I'm going to go into this in a little bit more detail over the next few slides, but this is the concept around, avoiding detergents, soap substitutes, regular emollients, and then reduction of inflammation. So this is using medicines or other interventions that dampen down the immune response in the skin to improve the eczema. And there's a fairly sort of linear escalated sort of line of treatments that we consider in eczema services, where we use skin-directed therapies. So often the medical term for that is topical therapy. If these fail, we then think about things like light therapy, the medical term for that being phototherapy, and then potential medications, so tablets or injections that may systemically affect your immune system to calm down the eczema. I'm now going to adapt that to how we approach this in conception and pregnancy. And again, as Ruchika talked, there are different aspects of conception and pregnancy. There's preconception and early pregnancy, so when the fetus is developing. There's late pregnancy, when the fetus is then largely growing with some ongoing development, and then the postpartum period. And when it comes to clinical evidence, there's kind of, I'm going to sound contrary. So the quality of evidence is relatively poor when it comes to conception and pregnancy, because large-scale clinical trials with interventions are generally not done in this population, which is considered higher risk. But at the same time, doctors or people in the healthcare community often share or publish their experience, and there are also ways of pooling that published experience to analyze it, to understand what's going on. And so on the left, this is the European document that Ruchika mentioned. There's a consensus document that helps guide doctors, clinicians, what to do in conception and pregnancy. So this is consensus from a group of experts across Europe who've also reviewed what literature there is. And looking at the right, this is to give you an idea of what kind of literature or evidence there is out there. But there are some large studies that try and pull together the data out there around certain interventions in conception and pregnancy. So this particular study is looking at the role of topical steroids and whether there's any associated harm. And I think the very basic concept here is that you have different levels of disease, and we can talk about ways in which you might define mild or moderate disease. But in those individuals with localized mild eczema, generally the focus of treatment is optimizing topical, so treatments that you're putting topically onto the skin, so topical treatments. Again, without it looking too complicated, the European Task Force document, which guides people like me in what to do, or we contribute to these pieces of work, talks through a stepped kind of algorithm of how you might want to escalate topical treatments. And the key message here is essentially there are topical treatments that we can use when you're planning to conceive, or in early pregnancy and late pregnancy. And there's a stepped care approach. The mainstay of treatment initially being the use of emollients to prevent the dryness of the skin and help restore some barrier function to the skin. And I touched on earlier the avoidance of detergents, so things that further reduce the natural grease content in your skin. But then if you're thinking about more medical approaches, there's reasonably robust data showing that topical corticosteroids are essentially safe in conception and pregnancy. The main caveat being is that uncontrolled large volume use of potent or super potent steroid may be associated with small for date or preterm birth. And so if you were in this situation, i.e. your eczema wasn't being managed with more moderate steroids, you were using large quantities of potent or super potent steroids, that you should be under medical review to understand whether you're using safe amounts, and if you were using high amounts, that you may need to escalate to other treatments, i.e. that this is not an adequate treatment for you to maintain adequate control. Again, you may or may not be aware of these different treatments when it comes to treating eczema. If steroids are ineffective, we often use steroid alternative immunosuppressant ointments, which target that inflammation in the skin, a group of medicines called topical calcineurin inhibitors. And again, there's data largely from the use of these drugs as pills, so medicines in patients who have transplanted organs. So these are medicines that can be used systemically to suppress the immune system, showing that these drugs are safe in conception and pregnancy. And so topical application, so through a cream or ointment, is also supported and recommended in consensus-based practice. Going back to the sort of paradigm of moderate to severe disease, practically speaking, so there are lots of definitions. This is just a definition from a Southeast London pathway that we use to guide escalated treatments in eczema. But as a doctor, if an individual cannot be controlled with topical therapy, so creams and ointments alone, I need to think about something else. So you might then define this individual as having more moderate or severe eczema. And in a pregnant individual, there are different ways we can escalate treatment. So in some situations, phototherapy may be appropriate. This is a picture of a medical device, so a UVB phototherapy booth. And this is essentially using a wavelength of light that has anti-inflammatory properties to calm down the eczema. Ruchika mentioned this briefly in her talk. For eczema, the standard regime would be have twice a week treatment, and that could be done over a prolonged period of, for example, 3 to 4 months. And this has been shown to be quite helpful at reducing the severity of eczema, and again, safe to use as a skin-directed treatment in pregnancy. And if a treatment like phototherapy is not effective or just not practical, you might not live near a hospital that has this, you might struggle to meet and be under a service that can access phototherapy, or through other commitments, you just can't commit to attending a medical facility for twice a week treatment. There are medicines that we do also use in women who are pregnant. Historically, for flares, corticosteroids, so tablet steroids, were or have and still can be used in this situation. The challenge with corticosteroids is, from the point of view of eczema, often the benefit of these treatments are short-lived. So they work quickly, they calm down your eczema, but when you stop these, your eczema can come back. So they need to be done in a controlled situation, and you also need to have a plan that if the eczema comes back, what your next treatment may be, because having repeated courses of corticosteroids can lead to other medical problems for the mother, and that, a bit like the use of large amounts of potent topical corticosteroid, has been associated with small for date babies and potential early and delivery. There are other drugs that we use that can also target the immune system, which is overactive in eczema. And again, some of these through data in patients with skin conditions or with eczema or with other related conditions. I mentioned the use of immunosuppressants in women with organ transplants, for example, where these drugs are used at much higher doses, but obviously you can't stop the medicines because you don't want to reject the organ. So these medicines, there is data showing that these drugs are safe to use in conception and pregnancy. Without going into these medicines in a lot of detail, and it can be discussed in the discussion if relevant, medicines do have potential side effects that may be outside of the effect on the baby, and so if you were being considered for a treatment, this would be a discussion between you and a specialist. This isn't the kind of treatment that you'd be receiving in primary care through your GP. And kind of what I alluded to, those medicines, I showed snippets from the licensing. So that's the document that comes with the drug where these drugs have been signed off, showing that these treatments are accepted for use in conception and pregnancy. But this is where it comes down to that individual discussion between the mother and the clinician, so the prescriber of the drug. And this is understanding what treatments have been used, what treatments have failed, what the impact is of the eczema on the individual, and what the potential benefit of the intervention may be, and what is known about that intervention when it comes to the safety or any reported potential harms when it comes to either the mother or the baby. So hopefully that's given an overview that essentially in women who are planning to conceive or in conception and early pregnancy through to late pregnancy, there are many treatment approaches that we can have when it comes to the sort of more medical management of active eczema in the skin, whether that's skin-directed topical treatment that for many patients will be all that's necessary, those at the milder end of the spectrum. And if that's inadequate or the eczema is far more extensive, there are other approaches, whether it's light treatment or systemic medicines that we know we can use. There are lots of resources out there. In the UK, this is a particularly good website for expectant mothers, and this isn't just related to dermatology treatments. This resource covers all medicines across general medicine, and it tries to compile what is known. So this is the best use of medicines in pregnancy website, and this is just a screenshot of one of those systemic drugs that I mentioned for eczema, an injection treatment called dupilumab. As you can see this talks in pretty plain English, so it's pretty straightforward to understand the benefits, the risks, what alternatives are out there, and what would be the impact of not treating. So this is really to help both the patient and the clinician in assessing the different options. And also, just to highlight, this event is co-badged through the National Eczema Society, but the NES website, although it doesn't have specific drug-related information around conception and pregnancy, is a very good resource for broader issues around the eczema and the management of eczema. So just to highlight these two different resources. So that's where I'm going to conclude my talk. So I'll let Gemma rejoin, and we're very happy to take questions and have a discussion as a panel.
Tremendous. Thank you very much, Rick. That was superb. So we're going to move on now to our panel discussion. If you've got questions, we've had some really super ones coming in. Do so via the Q&A button at the bottom of your screen. Great pleasure now to introduce our panelists. So we've got Rick and Ruchika on it, but also I'd like to welcome Purdy Kamali, who's an accredited GP with an extended role in dermatology and skin lesion management. She has particular interest in atopic dermatitis, so it's great to have her on the panel today. She is a very passionate educator. She teaches dermatologists, she teaches GPs, trainees and nurses in primary care, and she's very active in the Primary Care Dermatological Society. She's on their executive committee and also editor of their bulletin. So deeply committed to improving the management of skin conditions in primary care, and really recognises how significant those conditions, particularly atopic dermatitis being such a common condition, has on people who are living with eczema. So welcome, Purdy. Very good to have you on board. So are you all ready for some questions? We've had some good ones coming through. So I'm going to let you chaps decide who you think's best to answer these. So the first one, I'm concerned around natural labour and it leading to a big flare-up due to stress and tiredness, and how it may impact on me caring for my baby after birth. I'm therefore wondering whether a planned C-section would be more appropriate for someone with severe eczema. Any thoughts from the panel would be really appreciated. I don't know who would like to kick off with it. Maybe Purdy, you'd be a good person, sort of as somebody, the GP dealing with women on a sort of very holistic basis. Do you have any thoughts on that?
Yeah, I think it's a really interesting question. I would say if the mother is experiencing severe eczema, if they are under the care of a dermatologist, I think that's a very reasonable discussion between their skin specialist and their obstetric specialist. There is no good evidence, as far as I'm aware, that we would be pushing for a cesarean over a natural delivery. And in terms of stress and sleep that your questioner there has mentioned, again, a cesarean can be incredibly stressful on the body and could, definitely contribute to flare-ups just as much as any normal delivery would. I think another consideration is whether there is genital eczema, as this can cause issues during delivery with thinning of the skin and tearing of the skin. But again, I think this needs to be rather an individual discussion between the mother and the person looking after their eczema and the person looking after their pregnancy. So there's no right or wrong answer there. Cesarean section is now a choice for mothers to make. But again, it would need to be an individual discussion is what I would say.
Yeah, brilliant. I don't know whether Ruchika or Rick want to add anything to that.
I'll make a very brief comment. I didn't really go into, the broad strategy around how we treat eczema, even if we're just focused on topical therapies. But in eczema, particularly if it's more chronic, there is now quite wide acceptance that you might need to do some maintenance treatment. And so someone with unstable eczema or evidence of chronic eczema going into a period like delivery, they may want to be increasing their background treatment. And that might be a twice a week application to those hot spots, which you're predicting might flare as your eczema. And there's quite good data showing that maintenance approach will produce or delay flare. So that's quite widely done now in practice.
Great. Thanks, Rick. Ruchika.
I just wanted to come in and say one thing that I think most women go through this discussion of, should I have a planned C-section? Should I just go for it and see how it goes, regardless of background conditions? One thing to consider is, although a planned C-section does give you that a little bit more control and takes away some of that anxiety around what's going to happen, it is major surgery. And you have to think about how you're going to recover, how you're going to pick up your baby. You'll have dressing. So if you've got a lot of eczema around the abdomen and you're going to have some possible stitches or staples in, all these things need to be considered. So unfortunately, there's no magical way to get the baby out and for the woman not to have to go through a fair bit. So really, it has to be tailored to the individual, and you don't have to make that decision early on. You can start the conversations and see what your eczema is doing closer to the time. But yeah, there are, you've got to look at the pros and cons of both sides. It is major surgery and it might not necessarily make things easier for you when you're trying to look after your baby.
Great, thank you very much. Yeah, there's lots of considerations, aren't there, for what comes afterwards. Brilliant. So I'm going to move to the next one. So I'd be particularly interested in the treatment options available and tips for soothing hand eczema. Hand eczema is a real sort of problem, isn't it, for parents, male and female, and facial eczema during pregnancy, which doesn't respond to topical steroids. So face and hands during pregnancy, any particular tips there? Maybe Rick would be good to take this one first.
Yeah, so obviously stepping back, it's whether you're optimally using the topical therapies, kind of building them up, as I just mentioned. So the regular use of an emollient, so moisturizer, avoiding detergent, so how you're washing your hands, And actually with hand hygiene and how you're washing it, there are some tips around, not using really hot water, the frequency with which you're doing it, how you dry your hands, again, not doing it vigorously, but making sure you do dry your hands carefully and properly. And again, with localized eczemas, I mean, in many ways, we have you can, access the full spectrum of treatments. It's all about how much it's having an impact on you. But ideally, you would manage it with topical therapy. Are you using the correct steroid? Are you using it effectively, adequate quantities? Are you considering maintenance, as I just mentioned? Is it that you're treating it and it's improving, but as soon as you back off, you're getting flare? And then, as I mentioned, this group of drugs, the calcineurin inhibitors. So there's topical tacrolimus ointment, which is a steroid alternative. And again, because it doesn't have some of the other side effects that we may see with topical steroid, it can be used again in that maintenance phase in quite a relaxed way. And these are all treatments that we can use. We know that you can use these in pregnancy, whether it's on the hands, the face, for prolonged periods of time. But then if they're not working, you probably need slightly more specialist input, and whether that's through a GP with an interest, community dermatology, or through a more specialist, hospital-based dermatology department. So that's kind of my initial thoughts.
Great, thank you, Rick. I wonder whether this next one, Purdy might be a good one to answer. So it's slightly to one side. So I've had problems with dry eyes before when the eczema on my face flares. So I usually use Evolve gel eye drops regularly. However, according to the leaflet, it says do not use while pregnant. I'm wondering if anyone knows why this should be, if it's just a lubricating eye drop. So what about those things? Labels often say don't use in pregnancy, Purdy. Should we heed or should we just go ahead?
Yeah, I think clearly manufacturers of any drugs need to cover themselves a lot. So there are lots and lots of medicines that we use all the time in pregnant women that will have those sorts of warnings on the drug information. So whilst it's really important that you flag it with your GP if you're unsure, many of us will be prescribing products that do contain that information on the leaflet that is disregarded if you've done it in conjunction with your GP or your primary healthcare practitioner or whoever's treating you. Again, Dr. Wolf mentioned the BUMPS website. So if you're unsure about any of the medicines you're using, you can type your medication into that website and it should come up with some good advice. There's no reason I can see that you can't be using that eye drop. I think it's a Carbamate eye drop. So I can't see any reason why you can't use that in pregnancy, and it is simply just the drug manufacturers covering themselves. But it's always worthwhile running it past your GP.
Yeah, excellent. Very good advice there. Right. I'm trying to conceive. Unfortunately, I'm able to manage my eczema effectively with Elecon. In the past, I've had particular issues with my nipples, though. Thinking forwards, should breastfeeding stop if nipples are bleeding or weeping? Has anyone got any top tips on how to manage nipple eczema? I think you alluded to it earlier, but with breastfeeding, any top tips? Nipple shields, what should we be thinking about?
Yeah, I think it's really hard, isn't it, when you have eczema of the nipples? So again, as Rick mentioned earlier, being proactive. So if you know that you've had problems with nipple eczema in the past, looking after your nipples, at the end of that pregnancy is really important. So using your regular emollient moisturizer that's been prescribed to you, avoiding any irritating products around the nipples. So things like perfume shower gels, for example, and just using your emollient moisturizer that you've been prescribed as your soap substitute for cleaning the nipples. You absolutely can breastfeed if you have eczema, even if you have eczema of the nipples. That's really important to say. We can still use all of our topical treatments to treat any nipple eczema that comes. So you can use topical steroids on nipple eczema, even if you are breastfeeding. The general advice is to obviously keep well moisturized. Steroid creams need to be on the skin for an hour or two to fully absorb and have their proper effect. So if you've given the baby a lovely feed, once you've taken the baby off, you can put your topical steroid cream on, and as long as it's been in contact for that nipple for an hour or two, you can then use your emollient moisturizer as a wash to wash it off before the next feed, and that's perfectly safe to do, remembering that our steroid creams are just once a day.
Brilliant, Purdy. Top advice. That's brilliant. I'm going to change tack now slightly. We have somebody that's asked the question. I'm wondering why some trusts in the UK won't prescribe cyclosporin during pregnancy. I've been advised my trust does not do this, and I've failed dupilumab. Currently on JAK inhibitors, so can't conceive on these. I'd like to have children, but I feel like I'm running out of options. Rick, I think that might be one for you. So lady has obviously had a lot of difficulty with her eczema.
Yeah, so I mean, I can't speak specifically what the reason they would not be using cyclosporin is. I think in many, I mean, even that European task force document, because it came out in 2019 when dupilumab was a relatively new drug, you know, it's very supportive of the use of cyclosporin and in fact, other older immunosuppressants. There's a drug called azathioprine, which is also being used in conception and pregnancy. There are risks to cyclosporin in the sense that we know that this drug is broken down by your kidneys, and you know, particularly in women that might have a tendency in pregnancy to having kidney issues or high blood pressure issues, you know, cyclosporin may exacerbate that. So whether there are particular concerns from that point of view, but it's cautioned but not contraindicated in pregnancy. Obviously, you could seek a second opinion through another department. Again, it's quite a specialist decision. In our department here at Guy's Hospital, where we have a big practice, we do use some of the other biologics in conception and pregnancy. So as alternatives to individuals that may have failed dupilumab, albeit that those other biologics do have a similar mode of action. So again, it depends on the reason why dupilumab failed. Was it that it wasn't good enough, or was it a side effect of the drug? But there would be other therapeutic options. But again, it might be that you might need to seek a second opinion if you're hitting issues locally.
Okay, great. That's good advice. On another one, I have hand eczema. Should I wear gloves when I'm changing my baby's nappies? And what's the risk of a baby getting an allergy to the gloves? Ruchika, would you, as a new parent, what would you recommend?
So it definitely depends on what your eczema is like. So hand eczema is quite broad. Things that we always recommend to all parents, actually, I've developed a bit of a hand eczema as well, just from when you're rushing around and you've got to handle a baby, you might not be putting the emollients on. So if you know you've got hand eczema, when you wash your hands, try to wash with that soap substitute or that emollient. Pat dry, don't rub your skin too hard. Reapply your emollient. I know that's easier said than done when it's 3 o'clock in the morning, your eyes are burning and you just want to get back to bed. But you've really got to just maybe keep a pot next to your bed and just try and get something back on. And if the ointments are not working for you, maybe go down the cream route or the lotion route, just get something on. And then when the baby's sleeping, you can reapply. In terms of gloves, if it is really quite cracked and sore and you're concerned about sort of germs getting in as well, you can use gloves. Now, in terms of allergy, I'm assuming that you're referring to a latex allergy. So you can get non-latex gloves. So with the latex allergy, that's not the kind of allergy where, you know, someone touches it and they get anaphylaxis. It's usually a delayed response, like a type 4 reaction. So if you try the gloves that don't have latex in, you can try using some cotton gloves that you then wash regularly yourself. There are lots of little things you can try. I think my biggest advice to you would be to get personalized individual advice for yourself based on what the situation is at the time. And topical steroids, as we've discussed with the nipple eczema as well, they can be used if the baby's down for a nap. You pop the steroid on at that point, wash it off with the emollient. So you can really do all these things to try and get that eczema under control.
Excellent, very good.
Yeah,
I think.
sorry, Gemma. I'd also
Sorry, Purdy.
there's some really helpful information leaflets for people that are struggling with hand eczema. There's a great one on the National Eczema Society website, and there's also a really great one on the British Association of Dermatology website. So if you just type in how to care for hand eczema and look for those websites, they're full of great tips that Ruchika has covered, but just so that you can remember when you're in your newborn sleepless phase, they're really, really helpful.
Excellent. Thanks very much, Purdy. I'm just aware of the time. I think just one more very quick one. Is there any expression of the discussed treatments, corticosteroids and calcineurin inhibitors, in breast milk? I think that's a worry, isn't it, for any woman that's breastfeeding, that things might get through. What is the evidence that there might be some transmission into the milk?
So it's quite difficult to give very precise guidelines on what is a large quantity. In documents like the European Task Force, I'll start with the position because I mentioned that if you use large quantity, particularly of potent steroid, that there is a degree of systemic absorption, and it could even be considered like being on a low dose of a steroid tablet. but in their document, they talk about using 200 grams of a potent or super potent steroid a month. So that's quite a lot. I mean, that's 2 large tubes, that, you know, the 100-gram tubes, which are bigger than the toothpaste size tube. As I touched on, if you do use large quantities, there is a small amount of systemic absorption, and these medicines, so corticosteroids and calcineurin inhibitors, do pass into breast milk in small quantities. But essentially, the evidence and the sort of pragmatic understanding of what's going on is the amount of dose that would make it to your baby is not relevant. It's not physiological. So your baby is not going to be immunosuppressed from that. It doesn't, for example, impact on vaccination schedule. So that's why, you know, broadly speaking, these treatments are considered safe and appropriate to use in conception and pregnancy. But if you have concerns over large quantity, you should seek medical advice to be talking about what you're doing and whether that's considered objectively appropriate.
Tremendous. Thanks very much, Rick. So I think we're going to have to draw to a close on the Q&A session. And I'd just really like to thank both our speakers and also Purdy as our panelist for your great responses. That's been really helpful. And again, if you have extra questions that you feel haven't been answered today, really would direct you to the National Eczema Society website, eczema.org. So you'll find lots and lots of information there. Now, we would like to hear from you. Just to say, we have here a QR code. We're very interested in how skincare practices in babies affects their skin and immune system. So this is a research project that's going to be up and running, led by Professor Carsten Floor, my colleague here, you can see down on the bottom right hand corner. So some new research. So if you would like to take part in that, if you're planning to be a parent, if you are a parent with or without eczema, please just scan this QR code and you can find out a little bit more by completing this survey. Only a few moments to do, so that would be tremendous. Thank you. And then I think on our final slide, here we have another QR code. You can't do anything without a QR code these days, but it's very helpful, this one in particular, because this is the QR code that will allow you to fill in a brief questionnaire, just some feedback. So this will be feedback about the survey to see how today's event was, but also to try and identify new areas for covering in future webinars. We're really sort of led by you and the questions that you want to know. So if you can fill that in, we'd be really grateful to you. And we'll also be sending out an email that you'll all get tomorrow, which again will give you the links and the opportunity to feedback to us. So finally, a big thank you to everybody for joining today, and particularly for our panelists and speakers. Thank you very much indeed.